ISOMT Foundation. All right. So discussing about the evidence, what does the evidence says on the sacroiliac joint examination and the treatment? Well, the physiotherapy point of view, the literature lacks evidence. Okay, there have been a lot of conflicting evidences which says that in order to determine a sacroiliac joint or a pelvis treatment, the researchers are lacking. Okay, especially by most of the manual therapists. But there are strong evidences by in an osteopathic world, because we compile all the osteopathic, chiropractic, physiotherapy, all the evidences when we are taking our courses. Okay, so it has shown that when you get education and training in this particular area, your intra-tester and your inter-tester reliability is improved. Okay, believe me, if you hone your skills in the pelvis and the sacroiliac joint area, your low back pain patient will be very, very happy. Believe me that. We have seen results in like as few as 2 sittings or 3 sittings. The patients with sciatica, disc bulges, low back pain, whether it's a mechanical low back pain or a non-mechanical low back pain, they are very, very happy. Okay, so please make sure that you get a proper training and education in pelvis and sacroiliac joints. All right. So what we are going to kind of teach you, I'm going to demonstrate certain techniques, but it's an innovative way to kind of, you need to restore the mobility and the stability of pelvis and sacroiliac joint. Now, when we talk about the pelvis and the sacroiliac joints, well, we will discuss, because we have discussed about the intertester and the intra-tester reliability in our basic foundations of manual therapy. If you just kind of access our module 1 in our cohort program, which is the basic and the advanced foundation of manual therapy, inter-tester means, the reliability means that 2 examiners test the same thing, and intra-tester means, as the name suggests, that if I'm testing something, that if I'm repeating that test, there's some reliability in that. Okay. All right. So when it comes to the pelvis and the sacroiliac joint, you need to know that your pelvis and sacroiliac joint is made up of your pelvis, or the innominate, the 2 side bones that you see. Okay, I can quickly show you over here. I have a pelvis. Okay, this is called innominate. This is your pelvis. Okay, sacroiliac joints are the joints between your sacrum. This is your sacrum. Okay, if you see the central bone over there, which is like a pyramidal bone, and the joint between your pelvis and your sacrum is the sacroiliac joint. This line that you see, that's your sacroiliac joint. Pubic symphysis, if you know, this is your pubic symphysis. Okay, the joint between the 2 pubic bones. Okay, there's an articular disc over here. So we actually perform the examination and the treatment of the pubic symphysis in our detailed course as well. And then you have your hip joints, the socket. Okay, and then you have your lumbar spine, which is articulating with your S1. These are the S1 facet joints. Okay, so you have your lumbar spine over there. You have your innominates, pelvis. You have your pubic symphysis. You have your sacrum, which is very important. There are certain pelvis or the sacral spring recoil test that I will be talking about in my detailed course. Okay, so that's why I say if you see all these areas, it will benefit your low back pain patient in just 1 or 2 or 3 sessions. Okay, all right. So where all can this sacroiliac joint, or the differential diagnosis of your pelvis and sacroiliac joint can help? It can help your patient with sciatica, very common. Now you need to differentiate between whether it's a sciatica or it's a pseudo-sciatica. What is pseudo-sciatica? Pseudo-sciatica is the referral pattern of certain muscle trigger points, where you might have to do some soft tissue work, some dry needling, etc. You can have disc bulge herniation. Believe me, if you don't check the patient's pelvis and sacroiliac, disc bulge will not help, because disc bulge is very subjective. There are studies from Harvard Medical School which shows that most of us have disc bulges, but that doesn't mean that is a source of pain. Spondylolisthesis, if there's a break in the passive structures of your bone, your spine. Acute lateral shift, it could be like a list or a shift. Okay, sometimes patient comes to you with that, oh, I have a back pain over here, so they are like crooked. Okay, so they can have like a spasm on one side of the muscle, but their pelvis and the sacroiliac joints can also be affected. The research shows that you have to treat the pelvis and the sacroiliac joint first before treating the lumbar spine. There are a lot of authors which say that the pelvis and the sacroiliac joint has to be treated first before you come on to the lumbar spine. And if there's a patient who tells you that I have an excruciating pain on my low back pain, or I have like a terrible 10 out of 10 pain, or maybe 20 out of 10 pain, because believe me, sometimes patients say I have 20 out of 10 pain. So sometimes there can be a unilateral sacral extension. Now, what is unilateral sacral extension? We will discuss that in detail in our next pelvis course. And if you fix that, believe me, your excruciating pain patients will be very, very happy, including the hamstring strain, cramping, hip pain, knee pain. Now, when it comes to the knee, you can have a patellofemoral syndrome, and it all comes down the root cause from the pelvis and the sacroiliac. Okay. There could be a stiffness nerve entrapment. There could be an anterior innominate rotation. Okay, there could be an anterior innominate rotation, which can cause the change in your quadriceps muscle insufficiency, which can cause the knee pain. Heel pain can have a posterior innominate rotations. Okay, we will discuss all those rotations because understand this is just a 1-hour lecture. It will be difficult for me to explain all the things in detail. I will show you some demonstration when I send you the second meeting link in the WhatsApp group in a short while. Okay, so stay tuned. Lateral foot pain can be because of the pelvic outflare. So what are these terms called, like outflare, anterior rotation? We will discuss that in detail in our pelvic course, please. But believe me, your foot pain patients, your knee pain patients, your hip pain patients, and your low back pain patients will be very, very happy if you enhance your skills in pelvis and sacroiliac joint. Okay. All right. What does the research says? The research says that it is important to treat the pelvis and the sacroiliac joint first, including the pubic symphysis. Because if you see, your pelvis forms a tripod. Okay, this forms like a tripod, and there are compensation on the lumbar spine. Okay, so you need to fix the pelvis and the sacroiliac along with the pubic symphysis, which I'll be discussing in the pelvis course next following weekend, before you come on to the lumbar spine. Now, lumbar spine can be having an opening or a closing dysfunction. Okay, but why pelvis becomes important is because when you're walking, when you're standing, or when you're in a gravity dependent or an independent position, your pelvis plays a big role. Okay, so you need to kind of see the pelvis role as well. Okay, now there have been people who have been assessing pelvis and the sacroiliac joint, like standing spinal flexion test, the standing hip flexion test, seated flexion test, the spinal one as shown in the figure, long sitting test, or prone knee bending test. I can quickly demonstrate a seated flexion test for you, okay, and then a prone knee bending, okay. Guys, I'm again telling you there's a little technical error. Just in case the meeting ends, I'm going to send you another meeting link on the WhatsApp group, and you can join that, okay, if you want to learn more, okay. So I'm going to show you the seated flexion test on my subject over here, which is my sweet wife, and then I'm going to show you the long sitting test, okay. So in a seated flexion test, the patient is in a sitting position, okay. Okay, so the patient is in a sitting position, if you can see that, okay. I'm going to take the permission, always take the permission of the patient when you are trying to assess and treat these areas, okay, or tell the patient to do it themselves, okay. In order for you to see, I'm going to stop the share and you can see me in a bigger picture. All right. So is it okay if you just lift your shirt up a little bit, ma'am? Okay, you can roll it up a little bit. Okay, you can roll it up a little bit. I'm going to palpate her pelvic crest. I'm going to palpate her pelvic crest and the PSIS in the seated flexion test. Okay, so I palpate her iliac crest and her PSIS are right over there under my thumbs. Okay, so what and her feet should be supported. Okay, she should be on a flat ground. Her feet should be supported. I request her, can you please bend forward, ma'am? Breathe out and bend forward. Now, if you see the initial range, my left side thumb, this thumb was going a little higher. Okay. And can you come up, ma'am? Okay. Can you go down again? See my left thumb very carefully, and I always do a bilateral thing. Okay. Can you go down, ma'am? Yeah. Her left side starts going up when she bends forward in a seated flexion test. Her feet is supported. Her hips are in line. She should not be sitting on an uneven surface. And her feet should be supported. So I can say that her seated flexion test is positive on the left. But again, seated flexion test also has some limitations. Okay, so I will discuss in my pelvis course certain pelvis and the sacrum recoil tests. These are called spring recoil tests. So I will discuss that in detail in my pelvis course in the following weekend. Okay. So that was the seated flexion test. Next, I'm going to quickly show you the long to sit test. Okay. So please, can you lay on your back, man? Face up. Okay. Now this is can be, it has different names. It is called long to sit test. It is called supine to sit test. Okay. So the patient is in a sitting supine position. Okay. We try to square the pelvis first. Okay. And how you can do is like two ways. The patient can simply perform a bridge. Can you perform a bridge? If you can see over there. So patient is performing a bridge. Okay. Can you go down, ma'am? Is there any pain with that? So your low back pain patient might not be able to perform that. If they're not able to perform that, there is another way. Okay. So what I do is, please can you relax, ma'am? Okay. What I try to do is I take her legs, both the legs. Please relax. Please relax. Don't help me. I take it a little bit higher. I lean back and I gently move it back and forth. I gently move back and forth. If the patient says they have a lot of pain, try to do it very gently. Okay. Now I'm trying to check her medial malleoli. Okay. This will be discussed in detail in the course, guys. So don't worry. I'm trying to check her medial malleoli. I think her left side seems a little shorter. Remember, her left seated flexion was positive. Her left side seems a little shorter. Either she can hold the bed or sit up, or if the patient is in too much pain or an elderly person, you can have another person to help the patient to sit up. Or if it is the same gender, or if you're comfortable, I sometimes ask my patient to hold my hand now and please, can you sit up straight? And she sits up straight. And I think, yes, she has, in supine lying, she was having a short leg. But now when she sits up, her left leg becomes longer. That tells me it is short to long on the left side, which tells me that her left pelvis is posteriorly rotated. We will discuss that in detail in our pelvis course, but when she was lying down supine, her left leg was short, and then when she sat up, her left leg became longer. Okay, so that tells me there's a posterior rotation of the pelvis, and I will show you a manipulation to correct the left posterior innominate pelvis. Okay, thank you, ma'am. And don't worry, guys. I understand this posterior innominate rotation, supine to sit might be over your head, but that's why I tell people that these things don't come in like 1 or 2 days. You have to practice pelvis again and again. It takes time, and believe me, when you hone your skills in these things, it will be very, very comfortable, and your patient will really love you. Okay. I hope I'm loud and clear to everybody. All right. But some researchers have shown that these are certain false tests where the literature is conflicting. Okay, and I'll tell you why. Oops. So these are the like a statement which says that don't drink the pelvic colade. Colade, if you guys know what is a colade, colade is like a drink. We sometimes drink it's a rainbow-like drink. Okay, colade. So don't drink the pelvic malalignment colade. So there are certain myths that you guys have about pelvis and sacroiliac joint. The myths are that we can specifically palpate pelvic bony landmarks. That's actually a myth. You cannot. Okay. Another myth is, do you have any questions, guys? I hope I'm not going too fast. If you have any question concerns, please let me know in the chat box. If you can't hear me, please check your internet connections. Can you hear me? Thank you. All right. Thank you for responding, guys. So we think that we can palpate the pelvic bony landmark specifically. That's actually a myth. Certain authors says that there is a 2 millimeter or a 2 degree of sacroiliac joint rotation or translation. I showed you the sacroiliac joint. Some authors think that there's a little bit of a translation and the rotation. And I remember that even in our last pelvic course, we did mention that, but the researchers are conflicting on that. And some of the evidence says that we actually cannot. We cannot ascertain that there is some translatory or rotatory motion around the sacroiliac joint. Okay, you can't specifically isolate the movements around the sacroiliac joint. Let's talk practical honestly. Okay, we also think that the asymmetrical motion or the position of the pelvis, they can tell the position or the asymmetry inside a sacroiliac joint. Again, that's a myth. You think that the patient is having an anterior nominate rotation or a posterior nominate rotation, and you think that is affecting sacroiliac joint. Well, not necessary. The sacroiliac joints can be normal, but because what is going inside the joint, the gold standard, if you remember, is a fluoroscopic injections. That is a gold standard for diagnosing sacroiliac joint, which is giving injections under the fluoroscopy that we will discuss in the course. Okay, so the clear understanding of the pelvis and the sacroiliac joint biomechanics is still conflicting. Okay, excuse me. And as I said in the beginning, that you have to rule out the pelvis and the sacroiliac joint biomechanics in order to treat your lumbar spine. Okay, guys, please check your internet connection because few of them are saying that I'm not audible to them. So please check your connection. All right, thank you. All right. Now coming on to a little bit of a visceral and differential diagnosis of the low back pain. Now there could be a lot of techniques, whether it is abdominal, thoracic spine, lumbar spine, pelvis, myofascia. A lot of myofascial restriction around the abdomen, around the back, the thoracic, the hips. They all can contribute to your low back pain. So yes, I'm not a myofascial specialist, but I do work on the myofascia. They can work. So you can use your soft tissue procedures, dry needling, releases, myofascial, Graston, instrument assisted, whatever. So we have an instrument assisted course on our website as well by Chris Gillard. So the same has to be managed. You have to feel the fascia. I will show a demonstration of the fascia with light-handed, with what direction is the restriction, and in that direction you will have to work on. Okay. Somebody's asking about pregnancy disorders with low back pain, groin pain, ligament. Yes, we will talk about the pregnancy related, even in children in our course. Okay, because pregnancy related pelvic pains and low back pain is very common. Most of the people know that, yes, the ligaments are lax, but we will be discussing a little bit about the pregnancy. Dr. Kelly Wilson would be joining us. She is a pelvic floor therapist expert. So she will be joining us in the pelvis course. Okay, so please stay tuned for the pelvis course on August 26, 27. All right. So I'm going to quickly show you a technique of the myofascial, how sometimes I like to work on the thoracolumbar myofascia. Well, there are different directions that you can work, different pressures you can work. I'm just going to show one technique, okay? So my subject or my patient lays down in a prone position comfortably, okay? Relax, ma'am, okay? I'm going to request to expose her low back a little bit. Can you please expose the low back, ma'am? All right. So you can request the patient to lower the pants, but I will show you right now like this only, okay? You can put a towel, or how I like to do it is sometimes just see my pressure. Just see my pressure. One hand, I would like to put it on her lower thoracic. That's the lower thoracic. And my one heel of the hand, I would like to put it on the sacrum, okay? And my pressure is very gentle. That's her sacrum, and that's her lower thoracic. That's it. If you see a gentle pull, I'm trying to stretch or see for the restriction in the thoracolumbar dorsal fascia because they all connect to the sacral base over there, especially for your erector spinae muscle, okay? So you can do it in a longitudinal way like that with a gentle pressure, longitudinal way. You can do it in a horizontal cross-frictional way as well, okay? Like that, but make sure your pressure is light. You can do it in a diagonal way. You can gently do it in a rotatory way as well. So you have to play around with your pressure in order to see where is the fascial restriction. You can't simply do the massages like that. That patients have, I've seen a lot of manual therapists just doing the simple massages. I like to keep the pressure light. That's it. So that's my thoracolumbar fascia restriction. If the patient is like really stiff, I can go a little bit hard like that, okay? But I would not like to go with a lot of pressure. It has to be very gentle pressure. You can do this way. You can perform different techniques like that, okay? You can perform techniques like that, going all the way to the restriction anteriorly to your QL. Your QL is deep over there, quadratus lumborum, and your external obliques over there. You can work on the iliopsoas anteriorly. We work on the iliopsoas. We work on the pelvic floor as well, but that is for the myofascial class, okay? So that's how I like to work on the myofascial, especially the thoracolumbar dorsal fascia, okay? All right, thank you. That was just a small fascial techniques. The fascial restriction feels like when you feel the fascia, your palpation has to be good. When you feel the fascia, you have to feel the restriction in specific direction. Because what is fascia? Fascia is a connective tissue which connects your muscles, your bones, and even the organs. So there's fascia all over. Okay, it is an interconnecting woven-like structure. Okay, so there can be restrictions in the superficial layer, deep layer, there are subserous layer as well. I have shown that there are different areas as well where you can perform, and how much pressure to put, it depends upon the patient's condition. All right. All right. All right. Now, talking a little bit about the visceral issues, I covered this in my differential diagnosis of for the physical therapist. Well, your back pain patients, well, as a holistic clinician, you need to know that your back pain patients are not just the neuromusculoskeletal patients. They can be coming from your visceral organs as well. Okay. Yes, there can be myofascial restriction. There could be a trauma. There could be regional interdependence, like the kinetic thing I told you. The patient's feet could be a problem. The patient's ankle or foot alignment can be a problem. For example, sometimes I tell my patients who are in a long-standing postures or in a long-standing jobs, I tell them to just use like a good footwear, and believe me, it makes a difference in their back pain. Okay, your degenerative patients, they could be disc, nerve root, facet joints, ligaments, etc. Sometimes there could be infections or inflammatory diseases, especially in a world that we are living today. There could be a lot of inflammatory pathologies going inside your spine. There could be stiffness, but that stiffness can be coming from the residual pathology that they have recovered from. Maybe, say, for example, a fever, simple, a viral fever. A viral fever can cause stiffness post resolvement of that. Okay, your ankylosing spondylitis, your psoriatic, your osteomyelitis, tuberculosis, or excuse me. Sorry, I'm having a bit cough. Or your seronegative spondyloarthropathies. Not necessary that your RH factor, your HLA-B27, or your blood test will show that in your blood reports, but there could be seronegative spondyloarthropathies as well, and that is inflammatory in condition. Okay, patients can be having simple osteoporosis. Females can be having some OB/GYN issues, so you have to ask a female with her consent that do you have any OB/GYN issues? When was the last time you saw your OB/GYN doctor? Or is there any ultrasound available or not? Because there could be a pelvic inflammatory disease, there could be fibroids. Cyst does not lead to too much of back pain, because I know females can have a question to me saying that, oh, 80% of the females are diagnosed with polycystic ovary disease. But cyst, benign cyst or small cyst does not cause low back pain. It is the fibroids which causes more low back pain. Endometriosis, which is a fallopian tube problem. Endometriosis can refer the pain around the groin or the interior thigh. Okay, there could be sexual assault as well, which obviously you cannot ask directly. There could be an organ prolapse in a lady, especially in an elderly population, and there could be multiple pregnancy, multiple parity. Okay, female comes to me with 4 or 5 kids. You know where to work on, it's pelvic floor. There could be gastrointestinal problems, simple gastric problems, constipation, irritable bowel syndrome. I have seen with the people, especially with the elderly population, that simple constipation. If you don't ask the patients to work on their constipation, they can have a back pain because it is in the large intestine in your rectal. Okay, including some cancers, your lung cancers, your gastrointestinal, your kidney cancers, along with fibromyalgia. Okay, they all can lead to patients' low back pain. So it is very important to rule out all that. I see a question. Excessive lordotic posture and knock knees affect the condition? Yeah, definitely. But try to understand when these postural questions come to me, I ask my clinicians to further ask yourself whether it is functional or whether it is structural. If it is structural, you cannot do anything about it. Believe me. If it is familial, maybe the patient's mother or parents or grandparents has that kind of a posture or has that kind of a structure of the spine. You cannot change the structure of the spine until unless you're really working on the scoliosis. I'll just add some conditions over there. Okay. And that too also takes a lot of time, especially when you're working on the scoliosis. Okay. So when your patient says that, can you fix my lordotic posture or my flat back posture? I said, see, I'm not here to fix your posture. I'm here to fix your pain. Okay. Well, the main cause of increased lordosis these days are obviously your excessive sitting, your posture, your excessive thoracic kyphosis. So you might have to work on the entire spinal chain. Okay. Excuse me. Now, there could be some hormonal problems as well, especially in females, that could be causing the low back pain patient as well. I'll give you an example, especially with the adrenal glands, with the thyroid problems, with their prolactin, with their estrogen. If those areas are messed up, then it can cause low back pain. Somebody's asking me, PCOS can cause low back pain? No, it doesn't. Polycystic ovary does not cause low back pain. It interferes with the female cycles, and that too when the cyst is bigger in size. I have talked about this from a couple of gynecologists. Fibroids causes more pain, and that too big fibroids rather than cyst. Cyst does not causes back pain unless the size is big and it is impeding onto certain neurovascular structures. Okay, fibroids causes more pain. All right. Somebody's asking thyroid. Well, that's actually a big question, subjective question. Somebody's asking how does the thyroid contribute? Well, thyroid and the pituitary gland, it messes up with the entire axis of the hormones. And that's why when it messes up with all the axis of the hormones, especially the hypothalamus, pituitary, and the adrenal axis, which is contributed by the thyroid, it messes up all the neuromuscular skeletal system. Okay. Posture does cause pain. The spasm of erector spinae. What? Well, definitely the posture will cause pain. There could be spasm, but do you think that you could really work on that posture? The patient will definitely fall back into its posture again. Okay. So you need to work on the strengthening of the antagonist, which could be your abdominal muscles. Okay. If you don't work on the antagonist strengthening, just stretching and your soft tissue works will alone not help your patients. Please understand. That's what we tell people. And the Sarman statement, excuse me, and there was a statement by the Sarman that shorten what is long rather than stretch what is short. I repeat, shorten what is long rather than stretch what is short. That means that strengthen what is weak rather than keep on stretching what is short. Okay. Well, it depends upon the treatment techniques that I'm going to discuss right now, and I'm going to demonstrate certain treatment techniques for you. A couple of muscle energy technique and a couple of chiropractic. We don't really say chiropractic. We generally do manipulations, okay? Because manipulations, yes, they can definitely help your patients. It can be a quick fix. Keeping in mind your assessment is proper and you know what you're doing, okay? All right. Somebody's asking me about adenomyosis. Well, I'm sorry, I'm not very familiar of what is adenomyosis. You might have to elaborate that to me. A patient have no pain on forward bending, but patient on returning back. It could be a muscular thing. If the patient is having pain with returning back, then it could be a muscular thing, or the joints are not closing properly. We teach that in our detail in our proper course. Okay. Spondylolysis, you can manipulate, but leaving that particular segment because lysis is a breakage in that particular segment. You cannot manipulate the listhesis segment. You cannot manipulate the lysis segment, which is a breakage. So if there's a breakage on L5S1, I will not manipulate L5S1 or L4L5. I will not manipulate that area. If you tell me to manipulate the thoracic spine, I can do that, but I will not manipulate lumbar spine if there is lysis or listhesis. Okay, you might have to work on the stabilization regime over there. Okay, but we are talking about the pelvis and the sacroiliac joint over here, which is very important before you come on to the lumbar spine. If pain is on sitting, not on bending forward and backward, well, that means there could be many reasons, man. There could be your pelvic, as I said. You have to check the pelvis and the sacroiliac joint. Maybe the patient's pelvis and the sacroiliac joint is crooked. That's why their sitting posture or the sitting is causing them the problem. Second reason could be their sitting muscles or their anti-gravity muscle, which is your back muscles. They are weak. They are not properly supporting the spine in sitting posture. Okay, I see a lot of questions over there. Manipulation in LCS. LCS, I guess you mean by the lower Caesarean section. Well, we need to work on the strengthening part, okay? Especially in a pregnant female, post 16 weeks, I would like to work on the strengthening rather than the manipulation. But we can never be sure that we have isolated segment for manipulation. Yes, we can be sure that where to isolate the segment for manipulation HVLA. That's what we teach in our cohort program, that you have to segmentally assess and treat the patient segmentally. You can't be just doing a generalized manipulation. You have to do a proper segmental assessment in order to be more specific and isolated, okay? Yes, dry needling and acupuncture can help the patients, but again, these are soft tissue procedures. If there's a problem in the bony alignment, the sacroiliac joint recoil, then you will have to work on the sacroiliac joint recoil, please, okay? All right. I have to move forward, guys. I know you have a lot of questions about canal stenosis. Believe me, these, before you jump onto the lumbar spine, I repeat, please treat and assess pelvis and sacroiliac, whether it's a disc prolapse, whether it is a canal stenosis, whether it is any pathology shown on the MRI or the X-ray. My MRI or X-ray can also show a disc prolapse right now, but I will check. There are authors, especially like Gregory Johnson and many others, which says that you have to check and treat pelvis and the sacroiliac joint before you do the lumbar spine treatment. Okay. You can do manipulation techniques, which are sometimes called chiropractic techniques. We will be teaching all these techniques, including muscle energy, in our pelvis and sacroiliac joint course in the following weekend. Well, I would treat and check pelvis first. If the patient is having disc bulge and a canal stenosis together, I will still check the pelvis first, because that's a problem, that we are not educated and trained in checking the pelvis. Okay, so I will still treat the pelvis and the thing first, because that, when you do it, it ultimately solves the problem in the lumbar spine. Please understand that. Well, in detail, I could not show it right now. I'm sorry. In detail, the pelvis and sacroiliac joint assessment will be difficult. I will show that in my certification course, which is the following weekend. Okay, we have limited time, so I cannot, I'm sorry, discuss the assessment in detail. But talking about a little bit of a technique, you can do the myofascial technique, which I showed you. You can do in specific directions. You can do other soft tissue procedures like your Graston, like your gauche, your releases, your cupping, which has some conflicting evidence. You can do some muscle energy technique that I can show you on the sacrum. Well, before I do the technique, you have to see whether the patient is having that kind of obliquity as well. And believe me, I will be showing a lot of sacroiliac joint recoil tests, which are quite new, according to some school of thought in the US, which challenges or claims to fix a low back pain patient in just 1 or 3 sitting. Okay, you have to do mobilization or manipulation if the patient is ready for that. You can do pelvic floor assessment as well, and the treatment, especially for the females or elderly population. If you don't know how to palpate the levator ani or check the pelvic floor, you're welcome to check for Dr. Kelly's pelvic floor course. Okay, and Dr. Kelly will be joining us for the next weekend pelvis and sacroiliac joint course as well. Equally important, your exercise prescription. Okay, if you work manually, whether there's a soft tissue, mobilization, whatever, no matter how good manual therapist you are, but if you don't fix or you don't recommend some exercise prescription to your patient, the patient's back pain can come back again. It could be your abdominals, it could be your pelvis, and many other exercises that you can recommend post your manual treatment. As I told you, I'll be discussing about different spring and recoil test, which will really help you to fix your back pain patient in very few settings. Okay. Well, lubricant, I mean, you can use any lubricant that you want for doing the myofascial. Well, there is no specific technique for low back pain. You're asking me which is the best technique for lower back pain. It depends upon the assessment. That is a problem, guys. We jump on the treatment. Please don't jump on the treatment. Assess the patient first. What is causing the low back pain? Maybe I tell you this is the best technique and you do that technique. What is the guarantee that this will give you the result? Maybe the patient is having constipation. Simple. Differential diagnose. That's why this lecture is differential diagnose. I'll tell you XYZ is the best technique for the low back pain, and you do it on your patient and your patient doesn't get better. You will say, oh, sir, you told me this is the best technique, but you didn't check your patient first. You didn't assess and examine your patient first. Maybe the patient is simply having a high blood pressure, which can cause an abdominal aorta aneurysm, which can cause pulsating feeling in the low back pain. Or maybe simply they're having constipation or a gaseous problem, etc. Okay, so you have to please check and assess the patient first. Do a proper clinical reasoning. Okay. Yes, there are a lot of evidences on pelvic floor and low back pain. That's what Dr. Kelly will discuss in her part when she joins us in the following weekend. That we will discuss in our pelvis course, please. Okay. You're talking about the differential muscular involvement from the axial and in relation to the disc and the nerves. Yes, they all have a role to play. But as I said, please assess the pelvis and the sacroiliac joint functions first. Okay. All right. I will move forward to the low back pain. Okay. Simply a muscle energy technique. Okay. I will show a muscle energy technique. If you remember, I found out that her left side was posterior innominate rotation. Now, if she has a posterior innominate rotation, she can have sacral torsion as well, or she can have a unilateral dysfunction as well. So if she might have a unilateral dysfunction of the pelvis on the left side, it could be unilateral sacral flexion. Okay, what is that? We will teach you in the pelvis course, but I'll tell you a little bit. What she's having is, you're seeing this pelvis from the back side. This is her left side and the right side. Her left side is rotated back, posterior innominate rotated, and her left sacrum can be tipped forward, which is called sacral flexion. Okay, so please assess the patient first, as my humble request, before you start applying the techniques. Okay, so I'm going to show you a muscle energy technique on her sacrum, which is sacral flexion, and I'm going to correct her left posterior innominate rotation by giving her a manipulation. Okay, all right. So I would request my patient or my subject to turn on the stomach, ma'am. Now, if you see carefully, her left side, okay, say for example, if she had a left side problem, I'll show it on the right side so that it is close to the camera, okay? All right, so I'll show it on the right side, okay? What I'm going to do is, I'm going to bend her knee, okay? I'm going to take her right hip into abduction, a little bit of an abduction. I'm going to stand like so that her leg is on my rib cage over here. With the opposite genders, if you want to use a pillow or a cover or a towel pad in between the rib cage and the leg, you can do that as well. Okay. I'm going to palpate her ila. Okay. Try to do it over the clothing, if especially we are doing on the opposite gender. Okay. So I'll try to palpate her iliac crest, her PSIS, her sacral base. From the sacral base, I palpate her tailbone over there. And please remember, you take the patient's permission. So from the tailbone, I go 2 to 3 inches up and lateral, and that is her ila over there. That's her ila, okay? I take my hypothenar eminence and press onto the ila. So her right sacrum is flexed. So her ila, which is the inferior lateral angle, is tipped forward. So I'm palpating the hand on that ila like a speed bump, and I'm trying to press that speed bump down, okay? So what I want you to do, ma'am, when you take a deep breath in, I want you to push this leg into my rib cage, okay? And when you breathe out, I'm going to push onto your ila anterosuperiorly. Okay, so we'll do this 5-6 times. Okay, we can do this 10 times as well, depending upon your pain tolerance. Okay, so please, can you take a deep breath in and push into my rib cage, please? 1, 2, 3, 4, 5. Relax. And when she's breathing out, I'm pushing onto her ila anterosuperiorly. Okay, please take a deep breath in. Breathe out. When she's breathing out, I'm pushing her ila anterosuperiorly. I'll quickly show you on the pelvis. What I'm doing is, that's her pelvis. Okay, that's her pelvis. These two bony prominences called ila, and that is the sacral base. So what I'm doing is, I'm pushing her right ila down like that, simultaneously working onto her right hip. Okay, now I'm going to show you a manipulation technique for her left posterior innominate rotation. So please, can you turn that side, ma'am? So patient is in a sideline position. Okay, I flex her left hip. This is her left side on the top. Okay, can you straighten your lower leg, ma'am? Okay, put your left leg over there. I want you to hold with one hand onto the bed, and the second hand, I would like the patient to hold onto my wrist like that. And what I'm going to do is, I'm going to palpate her PSIS over here. I'm going to take the heel of the hand medial to the PSIS, and I'm going to hold her wrist like that, and I'm going to push her forward like that to correct her posterior innominate rotation. Okay, I can show the position like this. Okay, guys, again, if the video ends, bear with me. All right, if you see patient's position, okay, you can see it from the front. Okay, so she's holding onto the bed, and her one hand is holding onto my wrist. Okay, her one hand is holding onto my wrist. Hold it tight, ma'am. Hold it tight. And I'm pushing her PSIS with my hand. Okay, so I'll show you this technique a little bit posteriorly. What I'm doing is, if you can see, okay, can you please hold on to my wrist, ma'am? Hold it tight. Hold it tight. I'm holding on to her PSIS over there. PSIS over there. Let me show you a little bit more closer. That's a PSIS over there. Okay, that's a PSIS. Okay, please hold it tight. Hold it tight. Hold it tight. Take the end feel. Take the end, please. Please take a deep breath, ma'am, and breathe out. All right, if you hear that pop, that was the crisp pop on her L5S1 over there. Okay, so her pelvis was posteriorly innominated. I manipulated her anteriorly to fix that posterior innominate rotation. Okay, that was a manipulation, or you can say chiropractic manipulation, but we don't say chiropractic. We say simple manipulation to fix her posterior innominate rotation. And there are a lot of other manipulations as well to fix the pelvis and the sacroiliac joints. And believe me, your low back pain patients will definitely love you when you do all these techniques after a proper assessment. Okay, and as I said, I will be discussing a lot of spring and recoil tests as well in my pelvis course. Well, I understand it was a short and sweet course. It's already 8 p.m. But if you have any questions and concerns, please do let me know. Our course, this pelvis and sacroiliac joint that I'm talking about, it's a certification course. You will get a certificate and the video recordings along with the reading materials. It is a 6-hour course. It's a comprehensive and integrative approach to fix the low back pain. And Dr. Kelly Wilson would be joining with us on August 26th and 27th. Okay, it will be 5 to 8 p.m. Indian Standard Time, Saturday and Sunday. Okay, I would request or welcome you all to join for the 6-hour certification course online. And a lot of details will be discussed, including a lot of recoil tests, the spring test for sacroiliac joint, because the previous tests that we have been doing, like a standing flexion test or Gillette's test, that has been ruled out, and it has been shown that there are a lot of false positives. Okay, because standing position is an anti-gravity position. So that's why we have come across with the spring and recoil test. Okay, you guys are welcome to contact our team and follow us on our different social media platform. Sorry for the technical glitch in between, but I would really definitely would like to see you all in our pelvis certification course, which is 6 hours long. Okay. All right. Is there any question? I can take any questions before this meeting ends automatically. Once again thank you all to join us on a weekend evening to learn. I understand it was a short, concise overview, but if you really want to learn in detail, please sign up for our certification course. All right. Well, you have to rule out the root cause of the constipation, and that is a gastrointestinal problem, doctor's thing. Okay. While somebody's asking me about the video recordings and the certificate for this lecture are generally given to the people who are the premium members of ISOMT. You're welcome to go and check our website, theisomt.com, and become a premium member, and you will definitely get your certificate and your video recordings within a week. Okay. The pelvis and the assessment of the sacroiliac joint, it will make sense when you join our course the following weekend. Okay. All right. Well, I appreciate you all. Please follow us on the social media, Instagram, YouTube, Facebook. Check our website, theisomt.com. And